Thank you so much for that introduction. So my name is Areo Saffarzadeh. I'm a thoracic surgeon here at Mission Hospital, and I'm the medical director of thoracic surgery here. And so one of the things that I'm very passionate about is lung cancer screening, and I'm hoping to share that passion with you. Hopefully that you guys can help me get the word out. So let's jump right into it. So it's been 50 years. In 1971, President Nixon declared the war on cancer, launching a $1.6 billion crusade, which was a lot of money at that time. And now, 50 years later, President Biden just recently, this month, announced his cancer moonshot on the anniversary of JFK's Man on the Moon speech. And it's been 50 years, and we've been attempting to beat cancer. And one of our most effective tools we have for beating cancer is catching it early with cancer screening. And so lung cancer screening is very important, and I want to go through who's eligible for that and just spend a little bit of time talking about some background information. So we've always thought of heart disease as the leading cause of death for adults, but if we look at the group of adults between the ages of 45 and 75, cancer is actually the leading cause of death for those people. Over the age of 75, heart disease is then the leading cause of death. And when we look at the type of cancer that causes the most deaths each year, who we should be fighting this war against, who's our worst enemy, lung cancer by far is the leading cause of death. So 130,000 deaths due to lung cancer each year, 50,000 due to colon cancer, 50,000 due to pancreatic cancer, 45,000 due to breast cancer, and 34,000 due to prostate. So lung cancer causes more deaths per year than prostate, breast, and colon cancer combined. Now, when we compare that to the screening rates of these cancers, we do a really good job of screening for breast and for colon cancer, about 70% of patients. Prostate cancer screening, about 40% of patients. But lung cancer screening, only 5% of patients who are eligible to be screened are getting screened. And so that's why I've kind of made it my own personal mission to improve the screening for lung cancer. So I was really happy to see when the AAFP, which stands for the American Academy of Family Physicians, got behind the newest lung cancer screening guidelines that were published by the government, because their goal too is also to help preserve life. And the most effective way of reducing deaths from lung cancer is by screening high-risk patients. And that's the most effective way actually after quitting smoking itself. And so in your mind, you might say, well, let's screen everybody. And we do that for colon and for breast cancer. But for lung cancer, we only screen what we call high-risk patients. So who are those high-risk patients who need to get screened for lung cancer? So we had guidelines that were published in 2013. And the screening, there was 3 criteria. You had to be between the ages of 55 and 80. You had to have a 30-pack year smoking history, or you had to be a current smoker or had quit in the last 15 years. And just this past year, new guidelines were released, which increased the number of people who were eligible. So they dropped the age from 55 down to 50. So anybody between the ages of 50 and 80 is eligible, who smoked on average 1 pack a day for 20 years. We call that a pack year. So they had a 20-pack year smoking history. And they either had to be a current smoker or they had to have quit in the last 15 years. And so what is a pack year? So I said on average 1 pack a day for 20 years. Well, a pack year is just a way to describe the amount that you were smoking and for how long. So it's the average number of packs you smoked per day times the number of years you smoked. So you could have smoked 1 pack a day for 30 years, and that would be 30-pack years. Or you could smoke 2 packs per day for 15 years, and that would also be 30-pack years. So going back to these guidelines here, you could smoke 1 pack a day for 20 years or 2 packs a day for 10 years. And either way, you would still be eligible. You'd still have 20-pack years of a smoking history. Now, getting back to our screening rates, the US on average screening is about 5%. What's unfortunate is that the screening rates in California are really low. We're actually the second worst state in the country when it comes to screening for lung cancer. And it might be related to us having less smokers, so it's less on people's mind. But this is people who are eligible, who used to be former smokers, and only 1 or 2% of them are actually getting screened for lung cancer. So that's a number that I'm hoping to change. And the reason it's so important is that for breast and for prostate cancer, the reason, and even for colon cancer, the reason people are surviving is because we're catching cancer when it's early. And treating an early stage cancer is much easier and their survival rates are higher. For lung cancer, we're catching it when it's late and the survival is much lower. So after a lung cancer diagnosis, on average, survival is only 22%. Now, if you're caught with an early stage lung cancer, your survival is much higher. And we'll go through some of that data here. So our goal is to catch it while it's curable. And we do that with a lung cancer screening CT scan. So if it's detected at an early stage before you have symptoms, that's greatly going to increase the chances for cure and for survival. And that doesn't mean that if you develop symptoms, it's impossible to get a cure, but we want to catch it early. So I want to spend a moment here and just talk about lung cancer staging. So when we talk about lung cancer staging, there's kind of three things we look at. One is the size of the tumor. So tumors that are smaller are an earlier stage, and as they get bigger, their stage goes up. But actually, the size is not the most important thing. It plays a big factor, but the most important thing is whether it spreads to lymph nodes. And so when cancer, before it's spread to lymph nodes, your survival is still 60 to 90% at 5 years. Once it spreads to lymph nodes, and the N stands for lymph nodes, the chance of being around 5 years after you're diagnosed has dropped down to 50%. And these are if it's spread to lymph nodes inside the lung. If it spreads the lymph nodes outside of the lung, this represents the airway, then the chance of being alive 5 years later has gone down significantly, down to 30%. And if it goes to lymph nodes even farther away, then to 10 to 20%. And finally, if it's spread outside of the chest or outside of the lungs and you have metastases, then your 5 year survival, that's considered a stage 4 cancer. And there, the chance of surviving is pretty late. It's pretty small. There are some miracle stories though, so I don't want you to give up hope if you're in that scenario. Now, the data behind screening, so you say, okay, well, I'm going to get screened, but what's the evidence behind it? And the evidence behind it is pretty compelling. So it was one of the largest randomized studies, which are the best kind of studies that we look for in medicine, where they put people into one group and they don't tell them which group they're going to be in. And the people who are following them over time, they're blinded to the results. But they looked at 50,000 people and they put them who were heavy smokers or former smokers who were between the ages of 55 and 74. And these were people without any signs, symptoms, or history of lung cancer. And they randomly assigned these people into one or two groups. So 25,000 went into one group that got an X-ray every year, and the other group got a CT scan, and it was a low dose CT scan, meaning there was less radiation. And then what they wanted to see is over the course of the study, 5 years later, how many people were going to be alive in one group versus the other. And so this is what happened. The group that got the X-ray every year, when they were diagnosed with cancer, most of those were caught at a distant or late stage. So the cancer had spread far away and there wasn't really much chance for a cure. But those who were getting CT scans before they developed symptoms, their cancer was diagnosed at an earlier stage where it was more likely for them to have a cure. So a majority of those patients who were getting an annual screening CT scan, just like women get a mammogram or men get a colonoscopy every few years, every 10 years, if you were getting a screening CT scan, the chance of catching the cancer at an earlier stage went up significantly. And so what happened is that the survival rate was 20% higher in that group. And that's a really big deal. That's a really effective intervention. Now, I wanted to show you two CT scans, and this is two different patients. So here is a lung nodule. Nodule is just a term we use to describe, a collection of cells or something that looks abnormal in the chest. That's small, that's under 3 centimeters. This nodule for this patient was discovered on a screening CT scan. this patient didn't have any symptoms. They had this cancer treated, and they're alive today. This is a easily treatable small tumor. Now, this is a separate patient who's had a much bigger tumor who develops symptoms. And really, when you develop symptoms from a lung cancer, a lot of those times the cancer is really advanced. And so this is probably one of the hardest conversations to have, is to talk, about survival and the chances of curing it for somebody with a cancer like this. So hopefully that has motivated you, if you are a smoker or former smoker, if you have friends who are former smokers, to go out and say, hey, you guys know that you're eligible for a free screening lung cancer CT scan. It's the insurance are required to cover preventative screening exams for cancer. And so hopefully you'll get the word out. Now, let's say you get this screening CT scan. How do you interpret the information that you get? And so what's nice is that when you order a low dose screening CT scan, you get a score of 1 to 4. And that score tells you and your doctor what you need to do. So a score of 1 or 2 is really good. It means there's nothing that's really concerning. And 9 out of 10 people who get a screening CT scan will get a score of a 1 or a 2. And the chance of having cancer, if you get a score of 1 or 2, is less than 1%. And so for those people, they're just going to get a repeat CT scan every 12 months. And that's what we do until you reach the age of 80. Now, if you get a score of 3 or 4, 3 it's probably nothing, but let's just, check in 6 months instead of 12 months. For those people, about 5% will get that score. And the chance of having cancer is really low. It's like 1 or 2%. But cancer is a big deal. So we get another CT scan in 6 months just to make sure. If you get a score of 4, the chance of having cancer is actually a bit higher. And those are patients who have a tumor that's suspicious. And so either we'll get another CT scan in 3 months, or we'll probably do a biopsy. And so really any patient who gets a score of 3 or 4 gets referred to our, actually all the patients who go through our screening are enrolled in our program and get seen by our lung cancer screening program navigator, and that's Christine Riley. And so she is phenomenal, and she'll help coordinate your initial appointment and your follow-up appointments. She'll help, facilitate communication with all the different specialists, and really helps hold your hand and walk you through all of this. And so she's really a jewel for our program. And a lot of the funding for our program and our efforts are put forth by Mission Hospital and also the Cancer Institute. And so it's a comprehensive cancer center bringing together the leading specialists. And together we're doing clinical research, we're using cutting edge technology, and it's really important for us to provide compassionate care as well. And I want to just talk about some of this technology that I personally specialize in, and that is changing kind of lung cancer treatments. And so 2 of those are this robotic navigational biopsy. So this allows us to navigate to exactly where the tumor is in the lung and take a little piece with a needle. So it causes a lot less complications. And then surgery for those patients, we use the robot. And so a surgeon actually controls the robot on a separate console, but using my arms and my legs, we can control these 4 arms of the robot. And it gives us 3D view and better visualization and better movement inside the cavity. So instead of making a big incision on the side of the chest, we make a bunch of smaller incisions, keyhole incisions, and allows us to do the surgery so that you can get home quicker. And so through the Cancer Center, there's a lot of other support aspects there for patients. So genetic testing, rehabilitation, a dietitian, cancer support groups. And so we want to be there to support you through all of this. So I'll kind of just open it up for questions. And I left Christine Riley's number there. That's me and my little guy. This is Christine's number. This is her email. If you guys have any further questions, you guys can reach out to her.